We're now going to review some of the neurocutaneous syndromes. These are commonly on the exam. We'll start off with neurofibromatosis. It is autosomal dominant. Remember, you need to know modes of inheritance. It's an autosomal dominant disease, but there are a lot of new mutations with this disease. It can affect a variety of organs. There are some features that may be seen at birth, but usually you'll have delayed presentation. However, you'll be on the lookout for them because one of the parents probably has the disease and has passed it on to the child, so you'll be looking for them early on. Remember what chromosomes they're on. Neurofibromatosis is divided into NF1 and NF2. NF1 is the classic neurofibromatosis, also known as von Recklinghausen's disease. Now, the way to remember it is there are 17 letters in neurofibromatosis. You can count them now, or you can take my word for it. There are 17 letters in von Recklinghausen. It's on chromosome 17. That's a great coincidence. NF2, neurofibromatosis type 2, is on chromosome 22. So 2 for 22, 1, count the letters in the name. It's a clinical diagnosis. You need to have, for NF1, you should have 2 of the following. That would be greater than or equal to 6 cafe au lait spots. They need to be 5 millimeters in size prepubertal or 15 millimeters or larger in size postpubertal. Now, cafe au lait spots are these hyperpigmented lesions. They have very irregular borders, but they have very clear demarcation. Also look for axillary or inguinal freckling. You may have to have greater than 2 Lisch nodules that are seen in the iris, and you have to have greater than 2 neurofibromas or 1 plexiform neurofibroma. Or you can have osseous lesions or an optic glioma. All of these, you have to have at least 2 of those to make the diagnosis of neurofibromatosis. Here you have actually a neurofibroma. That large arrow is a neurofibroma. It's a firm, rubbery lesion. And these smaller arrows here, these are the cafe au lait spots. Okay? And you need to have a certain size and a certain number of the cafe au lait spots. This is a patient with multiple neurofibromas, varying sizes. They can be scattered anywhere. These tannish areas and these are the Lisch nodules. They're all over this particular patient. All of those are Lisch nodules. Complications of neurofibromatosis include CNS complications. They can have low-grade gliomas and hamartomas. They can have malignant neoplasms. They have abnormalities of the blood vessels. They can have seizures and cognitive defects. These patients require routine CT scanning to look for any tumors or neurofibromas in the head. Renal problems include hypertension, and they are at higher risk for pheochromocytomas. They're also at higher risk for other neoplasms such as leukemias, rhabdos, and Wilms tumors. Intelligence is normal with neurofibromatosis. Type 2 von Recklinghausen's, you need only 1 of the following to make the diagnosis. Remember, these are just criteria. You need to have a bilateral acoustic neuroma. Remember, this is autosomal dominant, so you may get a history of hearing problems in the family. Or you could have a parent and a sibling or a child with type 2 neurofibromatosis, and then the classification would be a unilateral 8th nerve mass or 2 of the following: a neurofibroma, a meningioma, a glioma, or a schwannoma. These are diagnostic characteristics for type 2. Most commonly, they'll ask you type 1 neurofibromatosis. Type 2 can present with hearing loss because of the acoustic neuromas. They can have facial weakness, headaches, an unsteady gait, and they may have some CNS tumors, and they don't have as many skin findings as type 1. That's why they might ask you type 2, because they have so much more findings. The management is genetic counseling. Again, this could have been a new mutation. Now you need to counsel that person when they become of childbearing age. And the parents, if they already have it, should know that they have a chance of having an affected child. Really, you don't need to do a lot of studies unless they have symptoms, but you do need ophthalmologic follow-up and CTs of the head. And you should also examine other family members with neurofibromatosis. Check their skin for any of the lesions. Tuberous sclerosis is another one of the neurocutaneous syndromes. This is also autosomal dominant. There's a wide range of manifestations of tuberous sclerosis within the same family even. There is a high risk of mental retardation with a earlier presentation. The hallmark of tuberous sclerosis are the tubers. These tubers can occur anywhere. They are like hamartomas. They can occur anywhere in the body. They can cause calcifications. They can, in the brain. They can cause seizures. They can also cause arrhythmias in the heart. I remember taking care of a little baby that had multiple episodes of VTAC, VFib. The patient also had some cutaneous manifestations, was diagnosed as having tuberous sclerosis. The baby had to have electrophysiologic studies that showed an area along the conduction pathway that had to be ablated. It was one of these hamartomas. In infancy, patients can present with infantile spasms. Look for the ash leaf spot. I'll show you a picture shortly. On CT scan, and they all need CT scans of the brain, you can see some of the calcified tubers. In childhood, the neurocutaneous the cutaneous manifestations are a little bit different. Look for the sebaceous adenoma and the shagreen patch, and we'll show you these in a minute. These patients can have more seizures. This is a patient with sebaceous adenomas. It almost looks like acne, but it's not an acne that goes away. These rough areas are the shagreen patches. The other skin lesion is basically, the ash leaf spot is a hypopigmented lesion that's found anywhere. So you have to really, on the skin, you have to really examine the skin carefully in these patients. These are calcifications noted on CT scan. Here, and also down here, multiple calcifications, and you can see that all of these can be causes of seizures. Complications of tuberous sclerosis include retinal lesions. Brain tumors are not as common, but you already have calcifications and seizures there. They can have rhabdomyomas of the heart, and half the patients will have those, and these are a source of arrhythmias like the baby that I just told you about. And a lot of patients can have renal lesions. They can also have lung lesions. The diagnosis is made on the clinical findings, particularly the skin, CNS, retinal lesions, and seizures. The treatment is seizure control, which can be very difficult at times because of these persistent calcifications, and also follow-up for the heart and chest and kidney. The Sturge-Weber syndrome, you saw a picture of Sturge-Weber syndrome in the first chapter when we talked about the port wine stain. These patients will have a facial nevus in the distribution of the trigeminal nerve. They can also have glaucoma in the eye on the same side as the port wine stain. Their most common presentation certainly is that port wine stain, but then they'll start having seizures in the first year of life. Again, these seizures are very difficult to control, and it can lead to mental retardation. Here's a child with a classic port wine stain of Sturge-Weber syndrome. You can see it covers the area of the trigeminal, and it's unilateral. These patients may have ophthalmos, kind of a large eye, and they can develop hydrocephalus. It is a clinical diagnosis. All patients, since they are at risk for glaucoma, require measurement of the intraocular pressure. They also need to have a CT scan done of the head, looking for any other manifestations. The management is management of the seizures. They can be difficult to manage, however. Sometimes the seizures are so difficult to manage because they can have a major calcification of that entire side of the brain. Sometimes you actually have to do hemispherectomies and do surgery for the epilepsy. The nevus for cosmetic reasons, or the port wine stain for cosmetic reasons, you can use laser dye therapy to get rid of it.